And as we're talking about this, and I try to give my kids real answers when they ask questions, what I recognize that it is just about the exact same mechanism that is destroying many of your patients' quality of life. Now that's the episode. Attention chiropractors, slayers of subluxation, unleashers of the imprisoned impulse, and protectors of the developing brain. Welcome to the Cranial Doc Podcast, where we master the work that actually changes lives. Craniopathy, nervous system-based care, and the business systems that let you scale without selling your soul. I'm Dr. Anthony Pellegrino, pediatric chiropractor, certified craniopath, and proud automation geek. Let's dive in. What is up there, subluxation slayers? So I'm in the car the other day, and my oldest starts being very inquisitive per usual and asking about one of his favorite subjects, which is ice cream. And so we're talking about ice cream. They had been giving a gift of a gift card to our local ice cream shop. For those of you guys coming to Foundations of Cranial Adjusting, now or in the future, it's Hoffman's. It's amazing. Actually, there's a bunch of, we're at the beach, dude, so like beach ice cream, super good spot. And there's a totally vegan ice cream place too that like don't sleep on in Asbury Park. But we could talk about that all when you get there. Not the point of this conversation. Foundations of Cranial Adjusting, thecranialdoc.com/training. Anywho, so he starts asking all of these questions about ice cream and, very specifically, brain freeze. And, you know, I've had brain freeze. My 5-year-old knows what brain freeze is. Your patients have had brain freeze. Their neurologists have had brain freeze. The ENT who told them that nothing was wrong with them has had brain freeze. Now, why are we talking about brain freeze? It is the most universal, relatable, laughed about headache in human history. Oh my God, I can't believe this happened. Thumb on the roof of the mouth trying to warm up the arteries. And as we're talking about this, and I try to give my kids real answers when they ask questions, what I recognize that it is just about the exact same mechanism that is destroying many of your patients' quality of life. Now that's the episode. All right, so let's talk about it, okay? What is brain freeze? Very cold hits the palate. The greater palatine arteries constrict quickly and then vasodilate hard as temperature normalizes. That swing activates pain receptors in the vessel walls. Now, those receptors fire through the greater palatine nerve. Thank you, Dr. Kim, Head and Neck, Gross Anatomy, Life University. Through the greater palatine nerve into the maxillary branch, the second branch of the trigeminal nerve, cranial nerve 5. It rides up through the foramen rotundum at the base of the sphenoid and hits the trigeminal ganglion. Trigeminal ganglion, trigeminal nerve. If we're going to be doing TMJ, working with the cranium, we better freaking know our cranial nerves. Now, the brain now receives the signal and reports pain in the forehead, behind the eyes, in the sinuses, all of these different places. Now, of course, nothing actually happened there. That is referred pain. Again, the same reason that a heart attack sends pain down the left arm, the brain maps location based off of expectation of where the pain should be coming from, not origin. Now, because the second cranial nerve innervates the palate, the sinus, all of these different things, that area, like it doesn't really know exactly where the signals are coming from, and it just lights the whole upper face up. So when we press our tongue or our thumb to the roof of the mouth, we rewarm the palate, the arteries stabilize, the signals drop, and the pain is gone in 30 seconds. Now that is the whole mechanism. So let's talk about other things that kind of influence this. The structure that is sitting directly behind the maxillary sinus, right in the middle of this, is the sphenopalatine ganglion. It is the biggest parasympathetic ganglion outside the skull, and it sits in the pterygopalatine fossa, which is bounded by the maxilla and the pterygoid process of the sphenoid. It receives input from the trigeminal nerve and then outputs to the palate, to the nasal cavity, to the sinuses, and to the throat. In brain freeze, that ganglion gets a hard 30 seconds hit. Now, I want you to think about the location. I want you to think about where it's drawing input from. I want you to think about the trigeminal nerve as a whole. Your patients are not getting a 30-second hit. They are getting a years, decades long hit. So let's talk about that patient. They have chronic headaches, frontal or periorbital. They've been to the neurologist. The MRI is clean. They've been to the ENT. They've got chronic sinus issues. They take Flonase. They went to the dentist. maybe a night guard for the clenching, but nobody found anything. So they show up in your office after being told, don't do that, they're just going to hurt you with these migraines. You look at the palate, and oh my goodness, it's not narrow, it's not high, it is, I love the word, buckled. It is so compressed from years of subluxation, years of clenching, that it is literally compressing down at the intermaxillary suture. They have a ravine in their mouth. Now, I don't necessarily love breaking out cranial models all the time, but I think it's very important because none of your patients have really gone around palpating inside of the roof of anybody else's mouth. And they don't recognize that in their mouth, this huge buckling at the suture is not normal. So you have them touch the palate on your model and see how flat and nice it is. And then you have them touch the inside of their mouth and ask them what the difference is. Well, what is that in my mouth? See, that has been years of your cranium not appropriately developing and compressing and causing your clenching, or being caused by your clenching in a feedback loop. It is the root, one of the root causes of these migraines. Now, this is huge. Now, this is very important for us because we talked about how this ganglion sits between the sphenoid and the maxilla, and I talk all the time, and especially in the Foundations of Cranial Adjusting course, is that one of the most important things we look at is the interface in the cranium between flexion phases and external rotation phases. And as, for example, the sphenoid drives into flexion, it moves into flexion, the maxilla moves into external rotation. And when the maxilla moves into internal rotation, the sphenoid moves into extension, and that all happens at the same time. So the specific interface that we care a lot about, again, think about the location of these ganglion, is the sphenomaxillary palatine suture, which if that is restricted, well, if the sphenoid can't move into flexion, it's not going to appropriately drive the maxilla into external rotation. It is massively important in anyone who has a compressed palate, and it is massively important in any child with a gag reflex. And in fact, I believe that many of the bruxism cases in adults that I see, which is a huge part of my practice, okay, I believe that almost all of them had hypersensitive gag reflexes when they were younger, and that the way that their body attempted to stabilize that is by having that bruxing pattern. Anyway, in these cases, the sphenoid's involved almost every time, the maxill's involved, the jaw is deviated almost every single time, whether it's because of the temporal rotation, the frontal rotation, compensation, or just because the sphenoid's been so effed that there is imbalance on the pterygoid muscles that are attached to the pterygoid plates and pterygoid processes, and then now as the jaw can't move, it's getting inappropriately pulled from side to side, and they show up in your office having done everything and not having any idea what is actually wrong. What they actually have is a structural challenge, structural subluxation that is overloading the sphenopalatine ganglion. The fossa is compressed, or at the very least inflamed, but in many of these cases, because it's been going on since they were a baby, it's not just it didn't develop appropriately. So that fossa can be smaller, okay? Just like the palate can be narrow, can not even have enough room for their tongue to rest on the roof of their mouth. This ganglion has been sitting mechanically or chemically compromised in this space for years. And every symptom that they have gone through, going everywhere, trying to figure out what's going on, has been going directly into the territories that the ganglion control. Now, this is very important for us because this ganglion is not just something that sits there, it is something that everybody knows about. Some of these patients have had nerve blocks injected with a needle directly into this ganglion in an effort to help. It is known and it is a target in the medical community to help these cases and has been for years. They know that this is a problem. They just don't know that you have the solution. Sinus pressure. The nasal branches of the ganglion are chronically irritated. Jaw tension. Chronic pterygoid loading from the compressed fossa. Upper teeth pain with no dental cause. Trigeminal nerve V2, referring directly into the maxillary arch. The neck that can't hold its adjustment. Upper cervical tension as a downstream response to chronic trigeminal load at the brainstem. Note there, this creates a feedback mechanism. I'm not saying that cranial subluxation is always causing cervical subluxation. In fact, it's often the other way around, but what often happens is that it creates a feedback loop where one causes the other. So in many cases, like if you adjust a sphenoid, We go over that there are specific things we need to check in the cervical spine. Otherwise, our adjustment does not hold because of the dural influence between the two of them. Either way, there is one mechanism with every single symptom that they walk in. I mean, let's take it even more simply. If you put pressure, a ton of pressure on the roof of your mouth, keep pressing, you can feel how that maxillary pressure is going to transmit through the vomer, into the ethmoid, through the sphenoid, all the way into the sinuses. Just do that right now. Put a ton of pressure into your maxilla, and you can feel that. Now, imagine if your patient's been experiencing that stuck for years and years and years and years. And now imagine if you can deliver not just a general release, but a specific chiropractic adjustment for a specific subluxation pattern with a specific vector, with a specific force at a specific time to correct the pattern. What happens for your patient? Everyone else is stuck looking at where it hurts. They try to figure out where it's coming from. The neurologist, boom, looks at the brain, MRI, case closed. ENT looks at the sinuses. There's no infection, no polyps, no chronic sinusitis. The dentist looks at the teeth. There's nothing wrong with them. They're probably crowded because the palate's compressed. Maybe tries a night guard at this age because who, outside of the dentist that you work in your office, would talk about palate expander in an adult? It doesn't make any sense. Except for it makes complete freaking sense because it's been going on since they were a child. Nobody looked at the structure housing that nerve that is referring into all of those locations. But again, the neurologist, they figured they'd been working with the sphenopalatine ganglion with the local anesthetic to treat these migraines and cluster headaches that don't respond to anything else. Put a needle into the pterygopalatine fossa and block the ganglion. It stops the headache, and it works. Just short term, because it's not going to change the structure. That is what you do. Specific chiropractic adjustments to address the specific compression at the intermaxillary suture, the sphenomaxillary palatine suture, the palatine bone, the intermaxillary suture, the interpalatine. Work with fossa volume, work with movement, make sure there's more space, look sure there's more function, less dural stress, less mechanical and nervous system load into the trigeminal nerve. Better input, driving the upper cervicals and allowing compensation to drop. You can't reach the suture from the outside. So that compression matters. This is something that requires our work. We are the ones that know how to work with this. We can quarterback with dentists when the case is too intense, when the compression is so great that they need a palate expander to be helped. But we better be there to make sure that it's going to start for the first time moving as they go through that process. But again, we need to know what we're doing enough to know when that is appropriate and how to be able to communicate that. Because that is how you can change lives. But knowing what that patient needs, know if you're the one to do it, know if you have to bring somebody else in, but overall making sure that that patient is going to get the exact care they need to be able to get better. Your headache and migraine patients have been everywhere and been told that there is no answer. It's definitely not structural. It's exhausting and it's demoralized. And they are skeptical because by the time they find you, because they've tried everything else. But the fact is, if they've ever felt brain freeze, they get it. Everyone has felt it. Their doctor has felt it. Their spouse has felt it. There is no defensiveness around it, no skepticism, no prior bad experience. It's just a thing when you eat ice cream like that. Your chronic migraine sufferers, tell them that they have chronic brain freeze. Oh, that's it. It's just the trigeminal nerve responding to a rapid temperature change at the roof of your mouth. Of course, we're not talking about a rapid temperature change at the roof of your mouth right now, but if you feel that thing that's in the middle of your palate, what I can tell you is that that roof of your mouth has been compressed and on fire for a long time. And I know that that's there before we even do this evaluation because I'm looking at the shape of your face and your bruxing pattern. Okay? Years of structural compensation. We'll go over when we go to the exam. That's it. That's how you do this. That's how you get them to get this. This is what we found. This is what's been loading the pathway. This is why you have the headaches that nobody else could explain. And this is what we are going to do about it. The decision to commit to care from this point forward in this conversation is not hard. It is easy because they get it. Because you see them. You understand them. You can see life through their eyes. More importantly, you can help their spouse who you got next to them with the report to see life better through their eyes. You get it.
Your most frustrated patients are the ones that are walking around with brain freeze. They just can't press their tongue to the roof of their mouth to make it stop. In fact, there's a good chance that their palate is so compressed that their tongue won't even fit there. But you get to help them. Listen, if you want to be able to know how to be able to see this, communicate this, address this, feel confident working with these cases, knowing how, what, and when to do to change the thing that they've been suffering with since they were a baby. Right now, at the time of this recording, our founders cohort of the Foundations of Cranial Adjusting course is sold out, which is awesome. But you can go to thecranialdoc.com/training and look at the upcoming trainings, as well as get on the list to be able to find out when new ones are announced. And I can't wait to see you there. Let's go change your community for the better. Go slay some subluxations.
Thank you for listening to another episode of the Cranial Doc podcast. I hope you got a ton of value out of today's episode. And if you did, it would mean the world to me if you jumped over to iTunes or your favorite podcast player of choice and subscribed, rated, reviewed, and shared this episode with a friend that you know could benefit. We have a ton of this information and more in our free email series at thecranialdoc.com. So go ahead and jump on there, subscribe, and get me raw, unfiltered in your inbox every week, changing your practice. Can't wait to see you for the next episode.